Hey everyone, today we're going to dive into a really powerful use for point-of-care ultrasound, checking out peripheral lung lesions. We're going to explore how thoracic ultrasound, or TUS, lets us get a really good look at these masses right at the bedside.
So here's our game plan. We'll start with the one absolute rule you have to know for a mass to even be visible. Then, we'll break down what a mass actually looks like on ultrasound. After that, we'll tackle the big one, telling a mass apart from a consolidation. We'll even touch on some quick-look staging and then wrap it all up with the key takeaways.
All right, let's get right into it with the most important principle. Honestly, before you even put a drop of gel on the probe, this one concept is absolutely everything. So, picture this. You get a CT report back that shows a peripheral lung lesion. Your first thought might be, hey, can I just grab the ultrasound and get a better look? Well, the answer is maybe, and it all hinges on one single critical factor. And this is it, the rule of pleural abutment. You have to remember, normal, air-filled lung is basically kryptonite for ultrasound. The sound waves hit that air and just scatter into nothing. It's an impenetrable wall. This means you could have a ginormous tumor in the middle of the lung, and you'd see absolutely nothing if it's surrounded by healthy lung. To be seen, it must be touching the pleura. No exceptions.
This is the teaching pro right here. If you remember one thing from this first part, make it this. It is a simple, black and white rule. Before you even try to scan a lung mass, pull up the CT. If you can see air between the lesion and the pleura, just stop. Save yourself the time, because ultrasound is not going to be the right tool for the job.
Okay, so let's say our lesion does meet the prerequisite. It's sitting right up against the pleura. What now? What are the specific features we're actually looking for to call it a mass?
First, let's talk about the basic look. A tumor usually shows up as this focal, distinct lesion right under the pleural line. Pay close attention to its borders. Unlike a nice, smooth inflammatory process, a malignancy often has these kind of jagged, angular, or lobulated margins. And then when you look inside the lesion itself, the echo texture is usually a mess. It's heterogeneous. And that makes sense, right? It's reflecting all the nasty stuff going on inside, like necrosis or fibrosis. Next up, look at how the mass is treating its neighbors. A tumor doesn't just sit there politely, it invades. And you can see this in the pleural line. That clean, bright white line you're used to seeing just disappears. It gets thickened, irregular, or sometimes it's just completely gone. And because that tumor is basically gluing the two layers of the pleura together, you will almost always lose your normal lung sliding right over that spot. Now here's a really neat trick. Both tumors and simple pneumonia can have air trapped inside them. On ultrasound, we see these as bright little spots called air bronchograms. But, and this is the key, the behavior of that trapped air can give you a massive diagnostic clue. Let's look at the difference.
And this right here is the whole story. In a tumor, the air is completely trapped and locked within that nasty tissue, so you'll see these few isolated bright spots that are totally static. They don't move at all when the patient breathes. Now, compare that to pneumonia. The air is inside airways that are inflamed, sure, but they're still connected. So you'll see more numerous, branching bright spots that are dynamic. They actually shimmer and move with respiration. This is a seriously powerful way to tell them apart.
And finally, let's throw some color on it. Putting on the Doppler gives us another layer of information. Tumors are greedy. They build their own messy new blood supply. So what you see is this really chaotic, often high-velocity blood flow that's clearly contained right within the tumor's borders. This looks completely different from the vascular pattern in a simple consolidation, which is usually more diffuse, low velocity, and branches out like a tree.
So all of this brings us to the main event. This is really the #1 reason we're doing this exam at the bedside, to take all those clues and confidently tell the difference between a malignant mass and a benign consolidation.
Okay, let's do a quick head-to-head comparison. It really lays it all out. When it comes to shape, a mass is nodular and angular. A consolidation, that's more wedge-shaped or even flame-shaped. For echo texture, a mass is a heterogeneous mess inside, whereas a consolidation is more uniform, what we call hepatization of the lung. We just hammered on the air bronchograms, static in a mass, dynamic in a consolidation. And finally, that vascularity, chaotic and contained in a tumor versus diffuse and tree-like in an inflammatory process. When you line all these up, the diagnosis often becomes pretty clear.
But we don't have to stop just at the lesion. One of the best things about ultrasound is that we can easily expand our view and do some rapid bedside staging for local invasion or even distant mets. This can be incredibly valuable information. Let's see how.
Here's a super simple but really high-yield checklist.
First, look at the chest wall directly over the lesion. Is the tumor busting out into the soft tissues? Look at the rib right below it. Is that cortex smooth, or does it look like it's being eaten away? Second, fan around and look at the nearby pleura and the diaphragm. See any suspicious nodular thickening? And third, just slide the probe down a bit, get a subcostal view, and take a quick look at the liver. It's such a common place for lung cancer to spread, it's always worth a peek.
All right, let's bring it all home. We've covered a ton of ground here, from the absolute basics all the way to the finer details of characterization and staging. Let's boil it all down into a workflow you can actually use.
So here it is. This is your whole thought process on one slide. Rule number 1, the gatekeeper. Is there pleural contact on the CT? If not, you stop. If yes, you proceed. Next, evaluate the margins and the internal texture. Look for that angularity and heterogeneity. Then, assess those air bronchograms. Are they static or dynamic? This is one of your biggest clues. After that, turn on the color Doppler. Is the flow chaotic and contained? And finally, don't forget to take that extra minute to expand your view and do a quick check of the chest wall, the pleura, and the liver.
And really, that's the bottom line here. Thoracic ultrasound is not a screening tool for every single lung mass. But when it's applied to the right lesion, one that's peripheral and touching the pleura, it becomes an incredibly powerful diagnostic tool that gives you a ton of information right there at the bedside. It's all about knowing when to use the right tool for the right clinical question.